Hello, 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 hello. जिंदाबाद।
यार मुझे कि मेरा मोबाइल
Hello.
Hello, Jean.
Hi.
Hi, Nawaz here.
Yeah.
1 second. We'll start right at 11. I have given you the co-hosting rights just in case you want to share.
Okay. I just want to try that slide. Huh? One second.
Sure.
One sec.
DP, ingat kiri cek.
Hello.
Hello.
Nawaz, it's possible that I will be disconnected. Unlikely, but it may happen. If it happens, I will be able to reconnect quite quickly. Yeah.
Sure, sure.
So
Okay.
if I get disconnected, just tell everyone that they should stay there. And
Definitely. Yes,
yeah.
yes, yes.
Once in a while, that.
Hello.
Can you see the screen?
It's loading. Yes, yes. Can see.
You can see. 1 second. Can you see this map?
Yeah, yeah.
And can you see it better now?
Yeah, yeah. It's
Okay.
full screen view. Yeah.
Okay, fine. So, okay. Now go back like this. Okay. All right. How many people are you expecting?
It was an open invite, so maybe 150.
Okay.
Yeah, about 100, 150 people. Yes.
And are we already live? No, huh?
Yes, we are live actually.
Okay. All right. Shankar, कैसे हैं?
कैसे हो?
बढ़िया.
बहुत
बहुत
दिन बाद
दिन बाद. आप तो आते नहीं है. आप पहले आते थे कभी कभी.
आपको भी आना है ना.
हाँ, मेरा आना भी बाकी है.
तो स्वास्थ्य ठीक है आपका?
हाँ, बढ़िया है. बढ़िया.
आज मुझे
आपका?
मैं ठीक हूँ.
आपके क्या बोलते हैं? नीज ठीक है?
हाँ हाँ ठीक है.
ओके, गुड.
नवाज
जी शंकर जी.
हाँ, कब आप बताओगे मुझे ना, कब चालू करना?
हाँ, हम लोग ठीक 11 बजे शुरू कर सकते हैं और आप वेलकम और जॉन का इंट्रोडक्शन दे सकते हैं.
ठीक है.
मैं अरुणा बोल रही हूँ. जिंदाबाद.
जिंदाबाद जिंदाबाद.
मैं तुम्हें नहीं बोल रही, जॉन को बोल रही हूँ.
हाँ, वो शायद स्क्रीन पे तो नहीं दिख रहे. जी.
अच्छा, आप सबको तो रोज रोज कहती हूँ उसको. मैंने कहा साल में एक बार कर दे. चलो.
Apa malah kang baca?
जिंदाबाद.
ऐसे क्यों हो रहा है? नवाज
हेलो
जी शंकर
जॉन,
जी.
मैं अरुणा बोल रही हूँ.
हेलो.
এখন ওই 32-এ ধরে রাখ।
जिंदाबाद
Dhanyavad. I can see many friends among the participants.
फ्रेंच हे आहे, रिसर्चर आहे, पण इंडिया बेस्ड आहे. खूप वर्षांपासून भारतात राहिलेला आहे.
उसको तो ना आएगा, हम ही आएगा ना.
सभी से निवेदन है कि वे प्लीज अपना म्यूट ही रखें. इंटरेक्शन का भी टाइम रहेगा. एक बार पहले जॉन जी थोड़ा बात रख लेंगे उनकी, फिर आप सवाल जवाब भी कर सकते हैं, इंटरेक्ट भी कर सकते हैं, लेकिन शुरुआत में प्लीज आप सभी अपना म्यूट ही रखें.
नवाज नवाज
जी शंकर जी,
आप मुझे बताओगे कब करना है ना?
1-2 मिनट में हम लोग शुरू कर सकते हैं शंकर जी.
आप बता देना, मैं उसी समय बोल दूंगा ना.
जरूर जरूर.
ठीक.
शंकर जी हम शुरू कर सकते हैं.
तो सभी साथियों को जिंदाबाद. आज भारत में स्वास्थ्य सेवा के अधिकार के ऊपर चर्चा करने के लिए हम सब इस मिल रहे हैं. एक टेक्निक के रूप में आमने सामने नहीं है, लेकिन फिर भी हमें एक दूसरे को खूब सारे लोग पहचानते हैं, जानते भी हैं, लेकिन फिर भी मैं आज परिचय दूंगा प्रोफेसर जॉन ड्रेज का. जॉन ड्रेज एक गरीबों के अर्थशास्त्री हैं, और ये ऐसे अर्थशास्त्री हैं जो पढ़ाते भी हैं, फिर पढ़ते भी हैं, और कॉलेज में भी पढ़ाते हैं. वहां से जो समझ बनती है वो लोगों के बीच में भी जाते हैं. मैं कहूँगा अपना हमारे देश का एक सौभाग्य है कि बेल्जियम के रहने वाले या इंडिया में आके इन्होंने भारत की नागरिकता ग्रहण की और यहीं रुके. और क्योंकि ये पूरे देश में खूब जगह पैदल घूमे हैं, और घूम के इन्होंने जो देखा और समझा उसको काम का हिस्सा भी बनाया. कई बार केवल लोग रिसर्च करने आते हैं और रिसर्च किताबों में रह जाता है, लेकिन प्रोफेसर जॉन ड्रेज रिसर्च को एक्शन में बदलने वाले व्यक्तित्व हैं. इन्होंने गरीबी पे, भूख पे, अकाल पे पूरी अपनी समझ बना के और इस देश में हमारे लिए टिके और लोगों के बीच में रहे. वैसे ही रहे जैसे आम जिंदगी में साधारण परिवार जैसे जीते हैं. तो इनकी जीने की स्टाइल भी आप देखेंगे तो वो भी बिल्कुल आम लोगों के उनके बीच में रहते हैं. बहुत महत्वपूर्ण व्यक्तित्व हमारे बीच में है. एसएफडी में आपका बहुत बड़ा योगदान रहा है इस सोच को पनपाने के लिए कि एक लोकतंत्र के लिए एक पाठशाला होनी चाहिए जिसमें हम लोकतंत्र के बारे में समझें. एमकेएसएस में भी हमारे यहाँ आए हैं, खूब घूमे हैं, और मैंने बहुत सीखा है जो से. इनकी किताबें जो लिखी इन्होंने, उसमें प्रोफेसर इनके अर्थशास्त्र में अमृता सेन के किताबों में बहुत बड़ा योगदान प्रोफेसर जॉ का रहा है. और सबसे महत्वपूर्ण ये कि आप लोगों के बीच में रह के इस काम को अंजाम दे रहे हैं. जहां मौका मिला, जैसे आप एनएससी में भी रहे, और उसमें रह के एक दबाव भी बनाया, उसमें अरुणा भी थी, हर्षमंदर भी थे, आपकी टीम ने दबाव बनाया कि नरेगा आना चाहिए, और नरेगा आया। और वो नरेगा की यात्रा में पूरे पता नहीं कितने राज्यों में बस लेके निकले हैं, जहाँ जगह जगह मीटिंगें करके पब्लिक की तरफ से भी दबाव बनाया और शासन की तरफ से सत्ता में वहां घुस के भी दबाव बनाया और महत्वपूर्ण कानूनों को अंजाम दिया। उसमें रोजगार गारंटी है, सूचना का अधिकार है, ये सब उसी का हिस्सा है। तो हमारा सौभाग्य है कि आज हम जों से सुनेंगे। वैसे जो गरीबों के बारे में इनकी जो समझ और वो सब है, वो सर्वगुण संपन्न है। मतलब आप सब चीजों को इनके साथ देख सकते हैं। उनकी शिक्षा की बात हो, राशन की बात हो, उनकी अकाल, नरेगा, पेंशन, सब मुद्दों पे आप जो से सब सीख सकते हैं, सुन सकते हैं, समझ सकते हैं। तो बहुत बहुत धन्यवाद जो का कि आप हमारे बीच में आज अपने अनुभव शेयर करेंगे।
शुक्रिया शंकर। शुरू करूं?
जी जी जी, बिल्कुल बिल्कुल।
आपकी बात सुनकर राजस्थान के दिनों की याद आती है, और खास करके रोजगार अधिकार यात्रा के दिनों की याद आती है। तो दोस्तों, आज मैं हिंदी और इंग्लिश की खिचड़ी बनाकर अपनी बात रखूंगा। पहले इंग्लिश में 2-3 मिनट का ट्रेलर सुनाऊंगा और उसके बाद असली कहानी हिंदी में शुरू होगी और इंग्लिश में समाप्त। So I'll begin with a few words in English to convey the main message of this talk. And basically, I want to make a case for the possibility of universal healthcare in India. Universal healthcare in the basic sense that no one should be deprived of quality healthcare is not a dream. It has already been largely achieved in many countries, and it is even becoming the norm around the world today, at least as an objective of public policy. The countries that have achieved universal healthcare, or at least that have a healthcare system based on the principle of universal healthcare, include not only most of the rich countries, with the main exception of the United States, but also a growing number of developing countries, including countries like Thailand and Sri Lanka, that were no richer than India is today at the time when they put that system in place. So there is no reason why India should not be able to do the same. We have been lagging behind in this field for many decades, and it is time to catch up. I think one important step for this purpose is to abandon the discourse of cynicism that tends to surround healthcare. Ever since I reached India 40 years ago, I have been hearing year after year that public health services have collapsed. Now, this is simply not true. Public health services are, of course, very poor, but over time, they have expanded and improved, not very much perhaps, but if they have improved in the past, then they can improve more in the future. And in fact, some states have already shown their ability to achieve rapid improvements in healthcare in recent years, including not only the southern states, but also some states of North India, like Chhattisgarh, Orissa, and of course, Himachal Pradesh. Further, the COVID-19 crisis has created a new public interest in healthcare and a new awareness of the critical importance of public health services. So there is no better time to demand universal healthcare, especially in the states that are better prepared for it. You may have heard that last week, 2 states have announced a commitment to a Right to Health Care Act, Rajasthan and Tamil Nadu. I think we must make sure this happens and then campaign for similar initiatives in other states. I will come back at the end, if time permits, to these acts and their potential and some of their limitations. But now let me turn to Hindi and take a look at what universal healthcare means and how it can be achieved. अब मैं हिंदी में अपनी बात रख रहा हूँ. दोस्तों, आज की चर्चा का विषय है स्वास्थ्य सेवा का अधिकार, the right to health care. इस विषय पर चर्चा करने का कारण ये नहीं है कि मैं स्वास्थ्य का एक्सपर्ट हूँ या इस पर बहुत काम किया हूँ. इसका कारण ये है कि भारत में स्वास्थ्य और स्वास्थ्य सेवा पर चर्चा करना बहुत जरूरी है और इस पर संघर्ष करना का लोहा भी गर्म है. स्वास्थ्य एक अजीब सा मुद्दा है. एक तरफ स्वास्थ्य जीवन की गुणवत्ता का आधार है. स्वास्थ्य के बिना कुछ नहीं हो सकता है. न काम हो सकता है, न खेल हो सकता है, न पढ़ाई हो सकती है, न खुशी हो सकती है. स्वास्थ्य सबसे बड़ी चीज है. उसके बावजूद दूसरी तरफ स्वास्थ्य की बात ही नहीं हो रही है. कम से कम सार्वजनिक मंचों पर, जैसे मीडिया देखें, संसद देखें, चुनाव अभियान देखें, इन मंचों पर स्वास्थ्य की कोई चर्चा नहीं हो रही है. उदाहरण के लिए अभी उत्तर प्रदेश में चुनाव हुआ है. हफ्तों तक चला चुनाव अभियान, महीनों तक चला, लेकिन उसके दौरान स्वास्थ्य की कोई बात नहीं हुई. तो इस खामोशी के कई कारण हो सकते हैं. एक ये हो सकता है कि जो बीमार लोग हैं उनका कोई आवाज नहीं है. एक कारण हो सकता है कि जो प्रभावशाली लोग हैं इनको सार्वजनिक सुविधाओं का कोई चिंता नहीं है क्योंकि वो लोग प्राइवेट हेल्थ केयर खरीद रहे हैं. और कभी-कभी मुझे लगता है कि इसका एक और कारण ये है कि अगर हम लोग स्वास्थ्य और स्वास्थ्य सेवा की बात शुरू करेंगे तो कॉर्पोरेट सेक्टर को मुनाफा कमाने का गुंजाइश कम हो जाएगी. The scope for profit making will be reduced क्योंकि पब्लिक को थोड़ा समझ में आ जाएगा कि स्वास्थ्य के क्षेत्र में सार्वजनिक सुविधाएं सबसे जरूरी है और प्राइवेट सेक्टर को रेगुलेट करना बहुत जरूरी है. इसलिए इस पर चर्चा होगी तो कॉर्पोरेट और बिजनेस सेक्टर को थोड़ा खतरा होगा. मुझे कभी-कभी लगता है कि ये भी एक फैक्टर है. उसके तुलना में आप डिजिटल टेक्नोलॉजी देखिए. डिजिटल टेक्नोलॉजी में मुनाफा कमाने की बहुत ज्यादा गुंजाइश है. इसलिए इसकी बात बार बार होती रहती है. आजकल पूरा मीडिया में, टीवी शोज में, जगह जगह डिजिटल की टेक्नोलॉजी लाने की कोशिश हो रही है क्योंकि इसको लाने में कॉर्पोरेट सेक्टर को काफी मुनाफा कमाने की गुंजाइश होती है. खैर, जो भी हो, हमको लगता है कि आज के दिनों में इस खामोशी को तोड़ने का एक मौका है क्योंकि कोविड-19 का संकट के कृपा से पब्लिक को थोड़ा पता चला है कि स्वास्थ्य का क्षेत्र में सार्वजनिक सुविधाएं और सरकारी हस्तक्षेप महत्वपूर्ण है. और जैसे मैं बोल रहा था कि कुछ राज्यों में भी एक घोषणा की गई है कि अगले कुछ दिनों में स्वास्थ्य का अधिकार अधिनियम लाया जाएगा. और एक्चुअली राजस्थान में स्वास्थ्य का अधिकार अधिनियम का एक मसौदा भी जारी किया गया है. तो इन कानूनों पर फिर से बाद में आएंगे. पहले हम लोग थोड़ा सा समझने की कोशिश करें कि स्वास्थ्य सेवा का अधिकार क्या है और कैसे लागू किया जा सकता है. तो सबसे पहले मैं स्पष्ट करना चाहता हूं कि मैं स्वास्थ्य सेवा का अधिकार की बात कर रहा हूं, स्वास्थ्य का अधिकार की बात नहीं कर रहा हूं. The right, I'm talking about the right to health care, not the right to health. अगर स्वास्थ्य का अधिकार की बात करेंगे तो हमें न केवल स्वास्थ्य सेवा की बात करना पड़ेगा, लेकिन पोषण, पानी, स्वच्छता, आवास, शिक्षा, पर्यावरण, न्याय, इन सभी चीजों की बात करनी होगी. और इन सभी चीजों को एक कानून में लाना असंभव है. अगर स्वास्थ्य का अधिकार पूरा करना है तो स्वास्थ्य सेवा का अधिकार कानून के अलावा कई कानूनों को लाना पड़ेगा और कई सामाजिक और आर्थिक नीतियों में भी बदलाव लाना होगा। इसलिए मुझे लगता है कि हम लोग स्वास्थ्य सेवा का अधिकार से शुरू करें, क्योंकि स्वास्थ्य सेवा का अधिकार अगर लागू होगा तो ये स्वास्थ्य सेवा का अधिकार अगर लागू होगा तो स्वास्थ्य का अधिकार की ओर एक बड़ा कदम होगा। जहां तक स्वास्थ्य सेवा की बात है, हमारा उद्देश्य क्या है, हम क्या चाहते हैं, क्या मांगते हैं? हम लोग यूनिवर्सल हेल्थ केयर, जिसको हिंदी में सबको स्वास्थ्य सेवा बोल सकते हैं, यूनिवर्सल हेल्थ केयर चाहते हैं, जिसकी अच्छी परिभाषा 1946 के बोरे कमेटी रिपोर्ट में दिया गया है। It's written, this is the Bore Committee report of 1946. It says, quality health services should be available to all citizens, irrespective of their ability to pay. सबको गुणवत्तापूर्ण स्वास्थ्य सेवाएं उपलब्ध होनी चाहिए, चाहे अमीर हो या गरीब हो। मेरे समझ में ये यूनिवर्सल हेल्थ केयर की एक मिनिमम परिभाषा माना जा सकता है। इस मिनिमम परिभाषा के हिसाब से आजकल पूरा दुनिया में यूएचसी यूनिवर्सल हेल्थ केयर को एक महत्वपूर्ण प्रयास माना जा रहा है। The principle of universal health care in this minimum sense is now well accepted around the world as a goal of public policy. For instance, it is accepted by the World Health Organization and also in the Sustainable Development Goals. लेकिन मेरे समझ में यूएचसी यूनिवर्सल हेल्थ केयर की दूसरी परिभाषा भी हो सकती है, और वो ये है कि न केवल सबको गुणवत्तापूर्ण स्वास्थ्य सेवा मिले, लेकिन सबको बराबर स्वास्थ्य सेवा मिले। Everyone should be in the same boat. That is a more demanding notion of universal health care. उदाहरण के लिए अगर इंग्लैंड की बात करें या क्यूबा की बात करें, तो वहाँ सब लोग एक ही स्वास्थ्य व्यवस्था में शामिल है, जिसको इंग्लैंड में नेशनल हेल्थ सर्विस कहते हैं। So we can call this not only universal healthcare, but universal and egalitarian healthcare. And I think this egalitarian dimension of UHC, of universal healthcare, tends to be forgotten a little bit in the contemporary discourse about universal healthcare, when in fact it was a very essential part of the vision of universal healthcare at the time, for instance, of the creation of the National Health Service in England. और ये समझना जरूरी है कि सबको एक स्वास्थ्य व्यवस्था में लाना केवल न्याय की बात नहीं है, लेकिन स्वास्थ्य व्यवस्था अच्छे से चलाने का एक तरीका है। It's not just a matter of equity, but putting everyone in the same boat is also a way of making the healthcare system more effective and more affordable for the society. इसका एक कारण ये है कि जब सब लोग शामिल है, सब लोग एक साथ है, सब लोग एक व्यवस्था में हैं, तो प्रभावशाली लोग कोशिश करते हैं कि गुणवत्ता के सेवा मिलें. The influential people try to ensure that the services are of good quality. और दूसरा एक कारण ये भी है कि जब एक ही संस्था सबको स्वास्थ्य सेवा उपलब्ध करते हैं, तो सिंगल पेयर सिस्टम बन सकता है. सिंगल पेयर सिस्टम का सिद्धांत समझने के लिए कोविड का टीकाकरण अभियान का याद रखें. दुनिया भर सरकार वैक्सीन खरीदते हैं और सबको टीकाकरण उपलब्ध कराते हैं. ऐसे क्यों करते हैं? वैक्सीन का बाजार क्यों नहीं होने दे रहे हैं? इसका कारण ये है कि जब सरकार के पास वैक्सीन खरीदने का मोनोपोली होता है, तो वैक्सीन सरकार को सस्ता मिलता है, क्योंकि खरीदने की कोई कंपटीशन नहीं है. भारत में वैक्सीन बनाने वाले कंपनियों ने बहुत कोशिश किया कि वैक्सीन का बाजार बने, ताकि उनको पैसे वाले लोगों से और निजी हॉस्पिटलों से अच्छा दाम मिले और उनका मुनाफा बढ़े. लेकिन अंत में पब्लिक का दबाव के कारण भारत में भी सरकार को वैक्सीन का बाजार बंद करना पड़ा और सिंगल पेयर सिस्टम चालू करना पड़ा. So I've been trying to explain that a minimum definition of universal healthcare is that healthcare should be quality healthcare, should be guaranteed to everyone, irrespective of their ability to pay, as is stated in the Bore Committee report. But a more radical definition would be that on top of that, everyone should be in the same boat. And the reason why there's a difference between the two is that universal healthcare does not mean unlimited healthcare. No country in the world guarantees unlimited healthcare. Universal healthcare is a guarantee of health services of minimum quality. And then the question arises, are we going to allow the privileged people to buy healthcare beyond that guaranteed minimum on the market? Are we going to allow a private healthcare market in addition to what is being guaranteed through the common healthcare system? Now, some countries allow that and some countries do not. The point I was trying to make is that the egalitarian approach may be the best way of organizing a healthcare system, not just from an equity point of view, but also from the point of view of making the healthcare system efficient and affordable for the society. Because when privileged people are allowed to buy extra healthcare on the market, in addition to what is being guaranteed through public institutions, they can divert healthcare resources, make healthcare more expensive, and reduce what is available to others, for example, by diverting the best doctors and paying them huge salaries. Now, not many countries in the world have a universal and egalitarian healthcare system, but it is interesting that some of the best healthcare systems in the world are those like the National Health Service in the UK that also are more egalitarian. अब चलिए हम थोड़ा सा देखते हैं कि दुनिया में यूनिवर्सल हेल्थ केयर, सबको स्वास्थ्य सेवा कहाँ दिख रहा है और कैसे कैसे लागू किया गया है. अभी मैं अपना स्क्रीन शेयर करने की कोशिश करता हूं. आपको एक नक्शा दिखा रहा हूं. नक्शा दिख रही है शंकर?
वो लोड, हाँ अभी दिख रहा है.
दिख गया.
अच्छा, ठीक है. तो ये नक्शा मैंने इंटरनेट से डाउनलोड किया है. इंटरनेट में इस नक्शा के अलग-अलग वर्जन्स होते हैं. They are not all identical. They may not all be accurate, but they give us an idea of where universal healthcare has been achieved, or at least where the healthcare system is based on the principle of universal health. तो भैया मैं घुस गया अपने उसमें. I think somebody needs to mute. तो इस नक्शा, ये आपको एक नक्शा दिखा रहे हैं, और इस नक्शा में नीला रंग के देश वही देश है जहां स्वास्थ्य सेवा का व्यवस्था यूनिवर्सल हेल्थ केयर के सिद्धांत पर आधारित है. यूनिवर्सल हेल्थ केयर 100% कभी नहीं होता है, लेकिन इन देशों में हम कह सकते हैं कि कम से कम यूनिवर्सल हेल्थ केयर स्वास्थ्य व्यवस्था का मेन सिद्धांत है. तो इससे आप देख सकते हैं, पहली बात यह है कि यूनिवर्सल हेल्थ केयर एक सपना नहीं है, कई देशों में लागू किया गया है. इट्स नॉट अ ड्रीम, इट कैन बी रियलाइज्ड. इनफैक्ट अगर हम पूछें कि नीला रंग वाले देशों में कितने लोग रहते हैं, तो अफ्रीका को छोड़ के, क्योंकि अफ्रीका में अभी तक कहीं नहीं दिख रहा है, अफ्रीका को छोड़ के दुनिया का लगभग आधा आबादी इन देशों में रहते हैं जहां यूनिवर्सल हेल्थ केयर लागू किया गया है. अच्छा, जो हरा वाले जो देश है, जैसे मेक्सिको है, साउथ अफ्रीका है, ये वहाँ यूनिवर्सल हेल्थ केयर लाने की कोशिश हो रही, लेकिन अभी तक पूरा नहीं हुआ. तो ये पहले बात है कि कोई सपना नहीं है, कम से कम 40-50 देशों में यूनिवर्सल हेल्थ केयर लागू किया गया है। और इन देशों में कैपिटलिस्ट देश भी होते हैं, पूंजीवादी देश भी होते हैं, और समाजवादी भी या वनपंथी भी देश होते हैं। इट्स अ जॉइंट अचीवमेंट ऑफ capitalist and communist or socialist countries. It is actually a socialist project. You can think of universal healthcare as being in the spirit of socialism. In fact, if you look at the Communist Manifesto, अगर आप Communist Manifesto पढ़ेंगे, उस manifesto में एक मांग पत्र है. There's a list of 10 demands which includes universal elementary education, and universal healthcare would have been a very natural addition to that list. So it's very much a project in the socialist vision, but it has materialized both in socialist or communist or formerly communist countries and also in capitalist countries. दूसरा आप देख सकते हैं कि जितने अमीर देश हैं, जैसे अगर हम लोग OECD के देश अगर देखें, जिनको रिच और मोस्टली कैपिटलिस्ट कंट्रीज माना जाता है, तो लगभग इन सारे देशों में यूनिवर्सल हेल्थ केयर लाया गया है, with the main exception of the United States. United States is still very far from universal health care. Let me see if I can show you something else. Okay, I'm not able to go to the next slide, never mind. तो यूनाइटेड स्टेट्स में यूनिवर्सल हेल्थ केयर अभी तक बहुत दूर की बात है, और इसका मुख्य कारण ये है कि वहाँ बिजनेस सेक्टर का बहुत बड़ा प्रभाव है, और जितने निजी बीमा कंपनियां हैं, जितने ड्रग मैन्युफैक्चरर्स है, जितने निजी डॉक्टर और निजी हॉस्पिटल है, वो सब मिलकर यूनिवर्सल हेल्थ केयर का विरोध करें। और यूनिवर्सल हेल्थ केयर का विरोध कई देशों में हुआ है। अगर आप नेशनल हेल्थ सर्विस का इतिहास देखेंगे, जब दूसरा विश्व युद्ध के बाद नेशनल हेल्थ सर्विस लाने की कोशिश हुई थी, तो वहाँ भी प्राइवेट इंटरेस्ट और खास करके डॉक्टर लोग इसका विरोध कर रहे थे, क्योंकि उनको डर लग रहा था कि हम इस व्यवस्था में शामिल हो जाएंगे तो हम अपना प्राइवेट प्रैक्टिस करके इतना नहीं कर पाएंगे जितना अभी कमा रहे हैं। कनाडा में भी जब यूएससी लाया गया तो वहाँ भी डॉक्टर लोग विरोध किए हैं। तो यूनाइटेड स्टेट्स में क्योंकि वहाँ बिजनेस सेक्टर का शक्ति बहुत है, अभी तक यूनिवर्सल हेल्थ केयर नहीं लाया गया। अगर इसके बारे में थोड़ा और जानना चाहेंगे तो मेरा सुझाव है कि आप माइकल मोर का फिल्म देखें जिसका नाम सिक्को है। सिक्को बहुत मज़ेदार फिल्म है, और इसमें समझने का मदद काफ़ी मिलती है कि यूनाइटेड स्टेट्स में अभी तक यूनिवर्सल हेल्थ केयर क्यों नहीं ला पाया गया है। अच्छा, तो ये अमीर देशों की बात है, लेकिन अमीर देशों को अगर छोड़ें तो आप देख सकते हैं कि नीला रंग के और कई देश हैं, जैसे इधर लैटिन अमेरिका में ब्राज़ील, अर्जेंटीना, चिले। ये 6 साल पुराना नक्शा है, तो आज का नक्शा अगर होता तो हमको लगता है कि मेक्सिको भी इसमें आ जाएंगे, क्यूबा तो पहले से उसमें है, और एशिया में चीन, थाईलैंड अभी इस नक्शा में हरा में है, लेकिन हमको लगता है कि आजकल नीला में आ जाएंगे, शायद वियतनाम भी उसमें आ जाएंगे, और हमारे बगल में श्रीलंका। So it is not only an achievement of the richer countries, it is becoming also an achievement of many poorer or middle income countries. और उसमें श्रीलंका और थाईलैंड जैसे देश भी है जो हमारे बगल में है, और जिनका पर कैपिटा जीडीपी जिस समय उन्होंने यूएचसी लाया, आज भारत का पर कैपिटा जीडीपी इससे ज्यादा नहीं था। जब थाईलैंड 20 साल पहले 2002 के आसपास यूएचसी लाया गया, तो उस समय थाईलैंड पर कैपिटा जीडीपी लगभग उतना ही था जितना भारत का आज का पर कैपिटा जीडीपी है। So if Thailand could bring universal healthcare 20 years ago, when its per capita GDP was not higher than India's per capita GDP is today, then India should be able to do something similar today. अब एक सवाल उठता है कि चलिए इन सारे देशों में यूनिवर्सल हेल्थ केयर लाया गया है, लेकिन कैसे लाया गया है? तो इस सवाल का मोटा मोटी मतलब यूनिवर्सल हेल्थ केयर लाने का मोटा मोटी दो रास्ते होते हैं. आई एम सिंप्लीफाइंग अ लिटिल बिट हियर, क्वाइट अ बिट एक्चुअली, बट मोटा मोटी दो रास्ते हैं. पहला रास्ता ये है कि स्वास्थ्य व्यवस्था को एक सार्वजनिक सेवा माना जाए. हेल्थ केयर एज अ पब्लिक सर्विस, अ फ्री पब्लिक सर्विस. आप सोच लीजिए, अगर आपके घर में आग लग गया तो क्या होगा? आप क्या करेंगे? आप फायर ब्रिगेड बुलाएंगे. फायर ब्रिगेड तुरंत आ जाएगा और आपका घर का आग बुझा देगा. ये नहीं पूछेंगे कि आप कौन है, आपका आईडी क्या है, आप एपीएल है या बीपीएल है, आप किस समुदाय या किस धर्म के हैं, अमीर है गरीब है. ऐसा कुछ नहीं. तुरंत फायर ब्रिगेड आएगा और आपका घर का आग बुझा देगा. उसी तरह अगर आप कोई पब्लिक लाइब्रेरी या कोई पब्लिक पार्क का इस्तेमाल करना चाह रहे हैं तो वहां आप जा सकते हैं. सबके लिए खुला है, कोई शुल्क नहीं है. सो दीज आर ऑल फ्री पब्लिक सर्विसेज. तो उसी तरह इंग्लैंड का नेशनल हेल्थ सर्विस अगर देखें तो वो भी एक सार्वजनिक सेवा है. इट्स अ फ्री पब्लिक सर्विस. अगर कोई भी बीमार हो गया तो सरकारी हॉस्पिटल या सरकारी स्वास्थ्य केंद्र जा सकते हैं. पैसा लाने का कोई जरूरत नहीं, आपको वहाँ सारा सुविधा मुफ्त मिलेगा. तो उसी तरह कई देशों में स्वास्थ्य व्यवस्था को एक सार्वजनिक सेवा बनाया गया है. England is the best known example, but that is also how it works, of course, in Cuba, also one of the best healthcare systems in the world, despite Cuba being still a very poor country. Spain में भी लगभग national health service उपलब्ध है. Nordic countries देखें तो वहाँ भी कई देशों में national service हो रहा है. And even Sri Lanka, to a large extent in Sri Lanka, 90% of the outpatient services are provided by public hospitals and public health centers. तो ये सबसे सीधा रास्ता है कि आप स्वास्थ्य सेवा को एक सार्वजनिक सेवा बनाएं. लेकिन ये रास्ता तब संभव है जब सार्वजनिक सुविधाएं अच्छे से काम करते हैं. This is not easy. You have to ensure high quality of public services and of course give them adequate resources. दूसरा रास्ता है सामाजिक स्वास्थ्य बीमा, social insurance. I'm not talking of private insurance. मैं निजी बीमा की बात नहीं करता हूँ. निजी बीमा और सामाजिक बीमा में बहुत फर्क है. सामाजिक स्वास्थ्य बीमा कई तरह का हो सकता है. कनाडा देखें या जर्मनी देखें, इजराइल देखें, जापान देखें, ऑस्ट्रेलिया देखें, इन सारे देशों में स्वास्थ्य सेवा, स्वास्थ्य व्यवस्था सामाजिक बीमा पर आधारित है. बेस्ड ऑन सोशल इंश्योरेंस और इनका अलग अलग सिस्टम है. लेकिन मुख्य सिद्धांत ये है कि सब लोग शामिल है. एवरीवन इज इंक्लूडेड. किसी को मना नहीं कर सकते हैं. यू कैन नॉट एक्सक्लूड एनीवन. गैर मुनाफा का बीमा है और मरीज को क्या इलाज चाहिए ये डॉक्टर लोग तय करते हैं, ना कि बीमा कंपनी तय करते हैं. क्योंकि निजी बीमा में एक बड़ा समस्या है कि निजी कंपनी हमेशा कोशिश कर रही है कि इलाज सस्ता से सस्ता दिया जाए और कई बार कुछ इलाज को मना भी कर रहे हैं खर्चा कम करने के लिए. सो इन द सोशल हेल्थ इंश्योरेंस सिस्टम, it is the doctors who decide what the patient requires. तो ये समझना बहुत जरूरी है कि निजी बीमा और सामाजिक बीमा में बहुत फर्क है. अगर सामाजिक बीमा का एक असली उदाहरण देखना चाह रहे हैं तो मुझे लगता है कि कनाडा इसका एक उदाहरण है. कनाडा इज अ फेडरल कंट्री, तो वहाँ अलग अलग प्रोविंसेस होते हैं और हर प्रांत में, हर प्रोविंस में सब लोग कंपल्सरीली एक ही सामाजिक बीमा व्यवस्था में शामिल है. एवरीवन इज इंक्लूडेड इन अ कंपल्सरी एंड यूनिवर्सल हेल्थ इंश्योरेंस सिस्टम फंडेड फ्रॉम टैक्सेशन and managed by the government. So this is completely different from a private health insurance system. और वहाँ भी कनाडा में अगर कोई भी बीमार है तो वहाँ कहीं भी जा सकते हैं, चाहे सरकारी स्वास्थ्य केंद्र या निजी स्वास्थ्य केंद्र, जहाँ भी जाएं मरीज को खर्च नहीं करना पड़ेगा, खर्च बीमा फंड से होगा। और सभी निजी स्वास्थ्य केंद्र इसी व्यवस्था में शामिल है और किसी को इस व्यवस्था से बाहर स्वास्थ्य सेवा खरीदने का कोई अधिकार नहीं है। No one is allowed to buy health care outside this common social insurance system. So it is an example of not only universal but also egalitarian healthcare system. अलग बात है कि कभी-कभी कनाडा में जो अमीर लोग हैं वो सीमा पार करके अमेरिका जाके थोड़ा कॉर्पोरेट सेक्टर से हेल्थ केयर खरीद रहे हैं, लेकिन इसको छोड़ के सब लोग एक ही व्यवस्था में हैं। तो कनाडा में न केवल सबको स्वास्थ्य सेवा लेकिन सबको बराबर स्वास्थ्य सेवा उपलब्ध किया गया है। सो मोटा मोटी दो रास्ते हैं, एक सार्वजनिक सेवा और एक सामाजिक बीमा, पब्लिक सर्विस एंड सोशल इंश्योरेंस। और कई देशों में दोनों मिलाकर कोई ना कोई मिक्स्ड सिस्टम बनाया गया, जैसे थाईलैंड देखें या ब्राजील देखें या कई देश देखें, सोशल इंश्योरेंस और पब्लिक सर्विस दोनों का इस्तेमाल किया जाता है। It is very important to understand that even in countries that rely mainly on social insurance to achieve universal health care, there is a big element of public provision of healthcare, and of course also a big element of regulation of private care. And the reason is that private provision of healthcare is very problematic for many reasons that are well understood in economics. These reasons include first and foremost the danger of exploitation in the private sector, because the patient is basically a sitting duck who doesn't, the patient doesn't know, they may not know what their illness is, they may not know what kind of healthcare they require. So they're a sitting duck for exploitative private hospitals. Another reason is the failure of private entities to engage with preventive work. For example, preventing smoking, preventing road accidents, preventing accumulation of polluted water, garbage, and so on and so forth. These are all activities that private entities don't take much interest in because they make money from illness, not from preventing illness. They may make some money, of course, from things like providing gyms to those who have money, but that doesn't go very far. And the big preventive activity, the big activities of prevention have to be done through public institutions. Other reasons include the pervasive role of externalities in health, and also the importance of social norms in the field of health. What we do for our own health often depends on the prevailing social norms, and often it's important to change these norms. For example, persuade people to wear a helmet or to quit smoking and so on and so forth. And that again requires some form of public intervention. So these limitations, or indeed these failures of private provision of healthcare, are quite well understood in economics. This does not mean that there is no role at all for the private sector, that it has to be always completely excluded. But it means that the role of private sector in health, or rather healthcare, is limited and requires strict regulation. I should clarify that I have used the language of public and private, but in health, what really matters is not public versus private. It is profit versus non-profit, because we should not forget that there is also, in many countries, a large private non-profit sector. For example, there are NGOs, there are churches, there are trade unions, there are religious institutions that run public health centers and public hospitals, sometimes some of the best facilities in the country. And that sector, of course, is very important. In fact, my friend Yogesh Jain, who's I think listening at the moment, drew my attention to the fact that instead of calling that the private non-profit sector, we can call it the public non-state sector. I think that's a good point. And so when we talk about the public sector in health, I think it's a good idea to include that private non-profit or public non-state sector. So now I'll conclude with a few words. I'm sorry, I'm talking a lot in English now because I'm running out of steam, but I'll conclude with a few words about what may be possible in India in the light of this international experience and the role of a Right to Healthcare Act. भारत का स्वास्थ्य व्यवस्था अगर देखें तो बहुत ही प्रॉब्लमैटिक है। सार्वजनिक स्वास्थ्य, सार्वजनिक सेवाएं की बात करें तो बहुत कमजोर है, कई जगहों में बहुत ही कमजोर है, और निजी क्षेत्र की बात करें तो उसमें बहुत शोषण हो रहा है। दोनों तरफ समस्या है, लेकिन जैसे मैं शुरू में इंग्लिश में बोल रहा था, सार्वजनिक सुविधाओं में धीरे धीरे थोड़ा सुधार दिख रहा है, and possibly because of these improvements, the share of the public sector in health services is actually growing today. It is not declining, it is growing, at least according to National Sample Survey data. I think that in India, at least for the time being, we have missed the boat of a national health service. National health service may well be the best approach to universal healthcare. In India, for the time being, this will be very difficult because the private sector is too entrenched and too big. But we can still try to put in place a system that has a chance to converge in the fullness of time towards a national health service. I don't think we can expect much from social insurance from the time being. India has some elements of social insurance, like, for example, this Ayushman Bharat scheme. But I think because the private sector is so heterogeneous and so badly regulated, we cannot follow something like the Canadian model. I learned last week that even in Tamil Nadu, one of the best organized states in India and one of the states with the best health systems, the private sector is almost completely unregulated because it does not allow regulation to happen. So the best we can hope for, I think, is something that you might call healthcare as an optional public service. And what I mean by that is that the basic principle would be that everyone has a right to the best possible healthcare in a public facility, free of cost, if they wish to utilize public facilities. That would not prevent those who wish to use private facilities from using them, but it would at least ensure that those who wish to use a public facility get quality healthcare free of cost in those in that public sector. I think that is possible today, certainly in some of the more advanced states like Tamil Nadu and Kerala, and hopefully quite soon in other states as well. So the basic idea is that if anyone approaches a public health facility, whether it's a public health, primary health center, CHC, district hospital, whatever, then that person will have a right to the best possible treatment at that place, free of cost, including consultation, drugs, diagnostics, emergency transport, and so on. And if appropriate treatment is not available there, then she would have a right to be referred to a higher facility, for example, from the CHC to the district hospital, again, free of cost. And as I said, if a person prefers to go to the private sector, to the private health care sector, that would be allowed. So it would not be an egalitarian system. It would still tolerate this dichotomy between the private and the public sector, which I think is not the best but it would still be a form of universal healthcare, at least in the sense that everyone would have access to quality healthcare, irrespective of their ability to pay. Now, I think this entitlement that I'm proposing, that basically anyone who wishes can have quality healthcare in the public sector, is a simple, effective, and comprehensive entitlement that will resonate with the public. And it will make a big difference because it will help people to demand quality services. If you look back at the other social legislations that have happened in the last 20 years, सूचना की अधिकार की बात करें, रोजगार गारंटी की बात करें, फॉरेस्ट राइट्स एक्ट की बात करें, खाद्य सुरक्षा कानून की बात करें, each of these laws is based on one very simple basic entitlement. सूचना का अधिकार ये है कि कोई भी सूचना अगर हम मांगे एक सरकार से तो 15 दिन के अंदर हमको देना पड़ेगा. नरेगा की बात करें तो काम मांगेंगे तो 15 दिन के अंदर हमको काम देना पड़ेगा. Forest Rights Act is also like that. So all of them has a very simple entitlement, and then of course there are many provisions built around that simple entitlement. But I think the success of these laws is partly because they are based on the simple entitlement that resonated with the public. तो उसी तरह स्वास्थ्य सेवा की बात करें तो हमको लगता है कि एक बहुत सरल और पावरफुल एंटाइटलमेंट की जरूरत है, and that can be the right to free and quality healthcare in public institutions if it is the option that people want to exercise. Now, as it happens, this is more or less the framework of the acts that are being proposed in Rajasthan and Tamil Nadu. I think the main challenge of these acts is to define the minimum standards that are being guaranteed. आप क्या किस तरह का सेवा का गारंटी दे रहा है ये स्पष्ट करना पड़ेगा. Or actually the main challenge is not to define these standards, but also to define a process that will, or an institution that will define these standards and improve them over time as and when resources make it possible. And the main problem, in my view, with the Rajasthan draft is that in the Rajasthan draft of the Right to Healthcare Act, it is left to the rules to define the standards that are being guaranteed. And that defeats the purpose of the act, because it's an act that basically says that people have a right to whatever the government decides. Now, that is not the idea. We must have an objective process to define what are the basic entitlements that people have. And then the government will have to do what is required to meet these minimum standards rather than leaving it to the government to define the standards. तो दोस्तों माफ कीजिए मैं ज़्यादातर इंग्लिश में बात किया हूँ. मैं अपनी बात यहाँ समाप्त करता हूँ. हम लोग मिलकर पिछले 20 सालों में तरह तरह के सामाजिक कानूनों के लिए लड़ रहे हैं. सूचना का अधिकार कानून, रोजगार गारंटी कानून, वन अधिकार कानून, खाद्य सुरक्षा कानून, और संघर्ष करते करते धीरे धीरे भारत में एक सामाजिक सुरक्षा की व्यवस्था दिखने लगा. लेकिन इस सामाजिक सुरक्षा की व्यवस्था में अभी भी कई कमियां हैं, और मेरे समझ में सबसे बड़ी कमी ये है कि इस व्यवस्था में स्वास्थ्य सेवा का अधिकार शामिल नहीं है. लेकिन अब यूनिवर्सल हेल्थ केयर लाने का समय आया है. जिंदाबाद.
Thank you, Jean. This is a very timely talk, especially like you mentioned कि राजस्थान में और तमिलनाडु में भी अभी सरकार ये कानून को लाने जा रही है. एंड सिर्फ राजस्थान और तमिलनाडु के संदर्भ में नहीं, बट मुझे लग रहा है इधर भी कई और राज्यों से भी लोग जुड़े हैं, तो सभी के लिए ये बहुत अच्छा एक टॉक रहा होगा. कुछ सवाल आए हैं तो हम लोग वो सवाल को ले लेते हैं. पहले जो चैट पे आए हैं तो उन सवालों को ले लेते हैं, और फिर ओपन भी कर देंगे ताकि लोग डायरेक्टली भी पूछ सकें। एक सवाल आया है यूट्यूब के चैट पे, त्रिलोचन जी ने पूछा है कि हम लोग जो एग्जिस्टिंग प्राइमरी हेल्थ केयर सिस्टम है उसको कैसे इम्प्रूव करें। फंड्स की तो ज़रूरत है लेकिन कई सारा वेस्टेज भी होता है, तो उसको कैसे इम्प्रूव किया जा सके।
मुझे लगता है कि बहुत कुछ किया जा सकता है। मेन समस्या ये है कि इस पर ध्यान नहीं दिया जा रहा है। हम संसाधन उपलब्ध कराएंगे, मॉनिटरिंग करेंगे, ट्रेनिंग करेंगे, कई चीजें को लेकर सुधार लाया जा सकता है और लाया भी जा रहा है। लेकिन इसके साथ मुझे लगता है कि ये जो स्वास्थ्य सेवा का अधिकार कानून है, इससे भी काफी मदद मिलेगा। क्योंकि इससे क्या होगा कि लोगों को समझ आएगा कि गुणवत्तापूर्ण स्वास्थ्य सेवा मेरा अधिकार है और लोग गुणवत्ता का स्वास्थ्य सेवा मांगेंगे। इस समय हम क्या देख रहे हैं कि कम से कम झारखंड की बात करें तो लोग स्वास्थ्य सेवा को अपना अधिकार बिल्कुल नहीं समझते। जब बीमार हो जाते हैं तो कभी कभी प्राइवेट डॉक्टर के पास जाते हैं, वहाँ उनका पूरा शोषण हो रहा है। कभी कभी सरकारी हॉस्पिटल जाते हैं, वहाँ बहुत कमजोर, बहुत पुअर सेवा मिलता है। लेकिन लोगों को लगता है कि सरकार मेरे को अपने कृपा से कुछ दे रहे हैं, मिला तो मिला और नहीं मिला तो नहीं मिला। आवाज नहीं उठा रहे हैं, शिकायत नहीं करते हैं। तो दिस राइट टू हेल्थ केयर एक्ट, वन ऑफ द मेन इन माय व्यू द मेन पर्पस is to make it possible, is to empower people to demand better quality. I think that will make a big difference in addition to all the other things that can be done to improve healthcare services.
स्नेहल ने एक सवाल पूछा है खास करके इंश्योरेंस के मामले में, कि डॉक्टर्स या हॉस्पिटल्स भी इन्फ्लुएंस हो सकते हैं इन इंश्योरेंस को यूज करने में। जैसे आप देख सकते हैं राजस्थान में चिरंजीवी योजना है और उसमें अभी तक तो 5 लाख था, लेकिन इस बजट के तहत उसको 10 लाख कर दिया है वो लिमिट। तो कई बार हॉस्पिटल्स क्या करते हैं कि एक फ्रॉड या फिर वो पैसा सरकार से कैसे लिया जाए। Probably it happens in collusion with the state, probably it just happens because they have the wherewithal to access or apply for it. So how can insurance facility be improved in that sense?
तो मैं इसीलिए बोल रहा था कि सामाजिक बीमा से मुझे बहुत ज्यादा उम्मीद नहीं है इंडिया में। लेकिन मुझे लगता है कि चिरंजीवी का स्कीम मैं ठीक से नहीं जानता हूँ, लेकिन मैं अंदाज कर रहा हूँ कि आयुष्मान भारत जैसे कोई स्कीम है। मुझे लगता है कि अभी के लिए हमको इन स्कीमों में ज्यादा से ज्यादा या केवल सरकारी या प्राइवेट नॉन प्रॉफिट इंस्टीट्यूशंस शामिल करना है। Then it will become a mechanism to support the public sector and to support the private non-profit, or what you may call the public non-state sector. I think we should go to the private for-profit sector only in circumstances of services that are not available in the public sector. For example, somebody may need a transplant, organ transplant, liver transplant, if it's not available in the public sector, then I would say, yes, perhaps there is a case for going to the private commercial sector rather than to let that person die. But in other cases, I feel that the social insurance system should mainly promote the public sector and the private non-profit sector. And some states are doing that by and large. So I think that is a way of fitting the social insurance system in the framework that I have proposed.
थैंक यू। विभांशु के कुछ सवाल थे। विभांशु, क्या आप पूछ सकते हैं उन्हें? हेलो विभांशु। और योगेश जैन जी के भी कुछ सवाल थे, आप उनको पूछ सकते हैं।
हेलो
या हाय
जी
विभांशु, आप पूछ लीजिए।
जी, नमस्कार, जिंदाबाद साथियों। मेरे 4 सवाल थे। पहला तो अभी तक हम डॉक्टर की जो सामाजिक स्थिति देखते हैं और पूरे जो चिकित्सा सेवा प्रदाताओं की सामाजिक स्थिति देखते हैं, तो उनमें लगभग ईश्वर की और देवत्व की स्थापना की जा चुकी है। तो इससे हम उनकी अकाउंटेबिलिटी तय नहीं कर पाते हैं, तो इससे कैसे आगे जा सकता है? दूसरा हम सवाल जन भागीदारी का है। हम अस्पताल तभी जाते हैं जब कोई बीमार हो, तो कोई बीमार या उसके परिजन अस्पताल के प्रशासन में जाकर कैसे ही कोई नागरिक भागीदारी निभा सकता है, और उसमें भी जब माइग्रेशन करना पड़े कस्बे और गांव में छोड़कर, और डेली इंटरेक्शन तो हमारा अस्पतालों से उस प्रकार से हो नहीं पाता। तो आखिर जन भागीदारी का कौन सा फॉर्मूला अस्पतालों के लिए हो सकता है? तीसरा सवाल वही जो बीमा और बेवरेज मॉडल और बिस्मार्क मॉडल के बीच का अंतर है, तो उसमें मुझे बीमे का जो सबसे बड़ा प्रभाव होगा वो स्वास्थ्य सेवाओं के विस्तार को रोकने के लिए हो सकता है, क्योंकि जब स्टेट पैसे खर्च नहीं करना चाह रहा है, तो मेडिकल कॉलेज से लेकर पीएचसी तक का जो विस्तार है, और उसमें भी जब हमारे पर पॉपुलेशन में डॉक्टरों की संख्या स्टैंडर्ड नॉर्म्स के हिसाब से बहुत कम है, तो क्या बीमा, मुझे नहीं लगता इस बात का सॉल्यूशन है। और चौथा सवाल जो इम्पोर्टेंट है वो राज्य की तरफ से सूचनाओं के एकत्रीकरण का है, डेटा को रिलेटेड है, कि आज भी हमारे यहाँ मृत्यु और बीमारी का पंजीयन उस प्रकार नहीं है। अ, अगर हम इंग्लैंड जैसे समाजों में देखेंगे, तो 300-400 साल पहले ही हर गांव, शहर, हॉस्पिटल में बीमारी और उनकी मृत्यु का ठीक ठीक कारण हम पता लगा सकते हैं। लेकिन आज भी हमारे यहाँ कौन किससे किस प्रकार मरा, और कारण कि ये हमारी स्वास्थ्य सेवाओं को सुधारने में बड़ा सहयोग करता है। और कोविड के दौर में तो हमने देखा कि राज्य ने इनकार कर दिया कि बहुत सारी मृत्यु कोविड के कारण नहीं हुई है, जबकि हम सच्चाई से वाकिफ है। तो ये मेरे 4 सवाल है।
Okay, I could not follow all the questions. Nawaz, will you summarize the questions? Or should...
Give me a second.
The first one was about accountability.
Yes, the first one was about accountability. Yes.
See, so once again, I mean, I would say the same thing as I have said about the improvement of the health services. Many things can be done for accountability, but one of them is a Right to Healthcare Act, because that will give people a sense of entitlement and power to seek redressal when there are grievances. So the Act will have to include, of course, very detailed provisions for grievance redressal. I mean, so I have only talked about the basic entitlement, but many things can be built into this Act. And if you look at the Rajasthan draft, there are many provisions for grievance redressal, and that's again one way of bringing accountability. I could not understand the question about social insurance, and he said it's not a solution to something, but I couldn't understand what it's not a solution to.
The second question was about
participation.
Participation,
Yeah.
bhagidari.
So I don't have much to say on this. This is not a talk about health policy. I don't. As I said, I'm not a health expert, so I don't want to pretend that I have answers to all these questions.
The last question was about data.
So he talked about the registration, the civil registration. Yeah.
Yes.
Not just that, but also about medical history and especially related to deaths and COVID,
right.
The most recent case. Yeah.
So, but what was the question?
उन्होंने पूछा कि राज्य की तरफ से सूचना एकत्रित करने से संबंधित है, तो मृत्यु और बीमारी का पंजीयन हमारे यहाँ अभी भी ढीला है, तो उसको कैसे, जैसे कि कोविड के दौर में भी देखा कि सरकार ने तो मना कर दिया कि हमारे पास डेटा ही नहीं है, या फिर लोग को
okay. So I think this question is important even independently of the Right to Healthcare Act. But it's true that in the Right Healthcare Act, one can include provisions both for the collection of appropriate data, including, for example, cause of death, but also, of course, for the protection of data. Both are important. So you can see this act also as an opportunity to make progress in some of these aspects of healthcare. So potentially it could be quite a detailed act. I mean, there are many, patients have all kinds of rights. So it would not be, so what I mentioned is what I think of as the most important entitlement, that anyone can get quality healthcare from a public institution. But along with that, you can build other entitlements, for example, entitlement to respectful behavior, entitlement to know your condition or to consent to the treatment that you are going to be given. And you can also put entitlements to certain kinds of information, data collection, and so on and so forth. So one can potentially build quite a lot of things in this Right to Healthcare Act. And that's one reason why I think this initiative is so important. But I was trying to identify what is the critical thing that will inspire people, catch the imagination of the public, and help to make this Healthcare Act a success and make sure that it makes a big difference.
So, Jean, if I may ask now, Yogesh, if the moderator allows me, two questions, more about the logistics of getting such a act or the adhiniyam to someone who's championed rights-based movement for food, information, and employment, but is that the one problem specifically in health at the moment that we need to surmount while we go for the act is that the present government is able to sell the Ayushman Bharat as India's UHC. This is the discourse that is being allowed. So how to call this bluff out and to be able to engage the public at large that this is nowhere near what getting right to good healthcare means, as well as this is not UHC. So this is how should this be done is a question. And the second is in the same line, that asking for this right at this moment about the process of it, is actually asking for good public health systems to run. So should it be like a demand-based work, or should it be expecting the largest of a state like Tamil Nadu is trying to offer because they are trying to do something? It's not. I'm not sure whether they are only so-called responding to the demands of the people. It's probably the welfare, some sort of a good government is trying to do this. So
okay.
So what would be the way forward is what I
okay. So I get the question. I'll take the second question first. I don't think that without popular demand or popular pressure, this is going to happen. If it happens at all, it will be in a very weak, if not useless form. In fact, right now, my concern about the Rajasthan bill is that it may create a bad precedent because it is so weak. As I said, it's basically an act that says that you are entitled to whatever the government decides.
Like Assam.
Well, I'm not sure. I think the Assam bill may actually be better, but the main problem with Assam is that it was not really implemented. Oh, okay, let me come back to Assam later. But what I'm saying is that even in Tamil Nadu mein bhi Jandava ke bina Healthcare Act will not come. In fact, I have just learned, as it happens, yesterday, from well-placed source, that contrary to the announcement of the health minister, this healthcare bill, right to healthcare bill, is in fact not going to be tabled in the next session of the assembly. It may come later, but I was told that what the health minister said is not going to happen. So I think even in Tamil Nadu, there's a need for public pressure. I think this is really the time for health activists in Tamil Nadu to come on the street and take the announcement of the health minister as a rallying point and demand that they should act on what they have promised. And then, of course, there will have to be a lot of, these bills are going to go through processes of public consultation. So I think the demand factor is bound to be critical if we want to get something that actually has teeth. The Assam bill, I feel the Assam bill is a little bit like directive principles. It doesn't really create any obligation, any enforceable obligation, but it creates principles. And I don't think that is necessarily useless. I think it's still much better than nothing, because it is something to which we can try to hold the state accountable. And the problem in Assam is that, so far as we know, there hasn't been enough effort to hold the state accountable to the principles that are in the Public Health Act. Now, your first question, you said, how can we point out that Ayushman Bharat is nothing like universal healthcare? That is something I have written about from the very day that Ayushman Bharat was announced. On the day it was announced, if I'm not mistaken, I wrote an article in The Wire called Ayushman Bharat Trivializes the goal of universal healthcare. I mean, there's no way. And they were also making huge claims that like it was the biggest health program in the world and all kinds of nonsense. Ayushman Bharat cannot be more than a small part of it. I mean, that's obvious, if only from the expenditure figures. I mean, to achieve universal healthcare in India, you'll have to spend at least something like 2% or 3% of GDP. And Ayushman Bharat is just a drop in the ocean. It's just a few thousands of crores of rupees. So there's absolutely no way that this can claim to be the route to universal healthcare. I would say at best it's something that the state governments can use to top up their efforts. As you know, healthcare is a state subject in India at the moment. And so any healthcare act, any right to healthcare act for the time being will have to be a state act. So the states have to somehow use their own resources to bring the right to healthcare, but they can make use of Ayushman Bharat to a very limited extent to facilitate this. I think that's all. That's the only role that Ayushman Bharat may have. And as I said, I think that they should use Ayushman Bharat to support the public sector and the private non-profit sector, or what you call the public non-state sector, and be very careful in extending it beyond that to the private profit sector, because then Ayushman Bharat can become a way of subsidizing corporate healthcare, and that could do more harm than good. I can see lots of hands coming up, so I'll stop here.
Aditi Priya, yeah.
Hi, Ram. So I am not sure if this is the right question at this moment, but I wanted to understand that even when there is a universal healthcare, that does not guarantee that the community who were facing denial of services or who were facing discrimination in accessing these services, things are going to change for them, or is there going to be? What do you see happening in the bill which is being discussed in Rajasthan or Tamil Nadu about this?
So I think that marginalized communities have the biggest stake in this kind of Right to Healthcare Act. As I said, the main idea is to empower people to demand quality services of which they are deprived at the moment. And even in the system as it exists today, the utilization of public health services is much larger for deprived communities than for other communities. I was looking at recently at figures for Tamil Nadu, and I was amazed to see the contrast between SC/STs on the one hand, and so there was SC/ST and then OBC and then the rest, and the contrast in the utilization rates of public health services. I mean, for the SC/STs, the large majority of health services now, at least in Tamil Nadu, come from the public sector, whereas for the non-SC/ST OBC, the bulk of healthcare, even in Tamil Nadu at the moment, comes from the private sector. So the marginalized communities have the biggest stake in the consolidation of public health services, and that is the main purpose that this bill will serve.
There is a question from Rahul. One second. In the aid-driven world, some public, non-state or non-profit healthcare institutions act as demand aggregators for for-profit private sector healthcare providers. The question is, for all the entitlements you mentioned, there is a competing private sector, and there is no effort to build a narrative that quality of services in public sector is poorer. The question is, how do we address this misinformation and the myth that the public healthcare is poorer?
Sorry, what is the misinformation?
Sorry, can I?
That the
The, quality, the misinformation is that the quality is poorer in the public sector?
No, so John, first of all, I wanted to address that, that public, non-state, or the private non-profit healthcare institutions, mostly they're aid funded, and there's no reason to make them holier than thou, because in some cases they are demand aggregators for the for-profit private sector, right? And we know how these mechanisms of World Aid and Health Aid works. So I think even if you go for a Right to Healthcare Act, these sort of NGOs should also have some sort of monitoring mechanism, because there is a for-profit sort of, now they are becoming sort of, pharma driven, and sort of, I don't want to get into the details of the nexus that is there. One point is that. The second point is, for all the entitlements that you mentioned in terms of right to work or say right to information, there was no, the basic agenda is for right to healthcare, but there was no competing private sector there. There was no one else providing those services. You have a huge private sector out here existing, which you addressed in the beginning, that it will be difficult to begin a law like that. But also the fact that there is this consolidated effort to spread this information, that the quality of service, healthcare service in the public sector is poor. For example, the SC/ST who is rich in Tamil Nadu, will they go to afford above, will they go and, to a public sector? That's the question, right? So my question is that even if you bring in the Right to Healthcare Act, how do we tackle this misinformation or this myth or this, let me say, this agenda from the public sector, that from the private sector, that the public sector healthcare is always poor and poor?
Right. Okay, yeah. No, that's a good question. But again, I would say that the Act itself will help. I think you're right to say that we have a kind of legacy. It's true that the public services have been very poor for a long time, and they're still quite poor in many places. In Tamil Nadu, they're reasonably good. But that, of course, is not the case everywhere. But even in Tamil Nadu, we have a legacy of a perception that the public services are poorer, which may not apply. But if through this act, we consolidate and accelerate the trend towards expansion of the public sector and improvement of quality of the public sector, then hopefully over time, people will realize that actually the public sector is better for them. And we will see accelerated migration back to the public sector. And that is why I said that this is an approach that at least has a chance to converge in the fullness of time towards something like a national health service. It's of course a tall order, because even in Tamil Nadu, the private sector is very large and very influential, but it's at least something that we can attempt. It's interesting, if you look at Tamil Nadu, I saw the figures recently. If you look at inpatient healthcare, I think it was for inpatient healthcare, or maybe it was for total healthcare, but the public sector provides half of the services, but it spends only 1/4 of the total expenditure, a little bit more than 1/4, it was 27%. So with 1/4 of the expenditure, the public sector provides 1/2 of the services. And I don't think the reason is likely to be that the private services are of higher quality. At least I don't think they're of higher quality to the extent that you would justify the private sector providing the same quantum of services at 3 times the cost. The private sector is spending three-quarters of the expenditure is private, 1/4 is public, but the private sector and the public sector are providing half of the services. So I think more likely, this is reflecting exploitation and overcharging in the private sector. So I think as and when this act and other efforts also continue to improve the public sector, we can hope that the public will realize that they are quite often better off in the public sector than in the private sector, and we can hope to see a continued migration towards the public sector. The first question that you asked, that you posed was correct. I mean, we have to be very careful, of course, that this distinction between private profit and private non-profit is not always very tight. And the main difficulty in supporting the private non-profit sector is that sometimes the profit sector masquerades as non-profit and so on. So these are things that will have to be thought about. But I do think that the private non-profit or the public non-state sector is important, and that we have to find ways of supporting it.
Sure, 2-3 questions from the chat. One is, where will the money come from? The second is, are there examples of community-driven by mutual aid or direct action? Any examples of that? And regarding the Rajasthan Act, it says that the people cannot approach the court for violation. So what would be the implications?
Okay. So the money, so the main issue with the money is that, of course, we need more money. That is for sure. Even with the budgets that we have, certainly in a state like Tamil Nadu, we could already guarantee quite a lot. I mean, in Tamil Nadu, most of the health services are already available in the public sector, including some sophisticated procedures like organ transplant and so on, at least to a certain extent. So even with the budget that we have, we could have a meaningful Right to Healthcare Act. But of course, it's true that we do need a lot more money. It's extraordinary that in spite of health being the most important thing for the quality of life, India has been spending as little as 1% of GDP on public health expenditure for decades. I mean, in international perspective, this is dismal. Very few countries in the world spend as little on public health expenditure as a proportion of GDP. So it must go up for sure, at least to 2 or 3%. In fact, there was a commitment to do that 15 years ago, which we could have tried to hold the government accountable to a little more, I think, but it didn't happen. The dilemma right now is that it's the central government that has a lot of money, and it's easier for the central government to mobilize resources than for the states. But as I said, healthcare is a state subject in India, so we can't really have a national Right to Healthcare Act so easily at the moment. And in any case, my view is that in the present atmosphere, it would be a mistake to count on the central government for this purpose, because the central government is hostage to corporate interests, aside from the secularism issue and so on. So I would not trust the central government to make a good job of a Right to Healthcare Act at the moment. I think it will allow the corporate sector to use the act for its own purposes. So I think we have to somehow count on the states to mobilize more resources, and they can do it. Over time, they can do it. I mean, there are ways. There's a lot of untapped potential for resource mobilization in India. For example, the state governments can use property taxes a lot more. I mean, the property tax rates in India are abysmally low, and that's under the control of the state government. So there are ways of raising more money, and that's the only way forward.
Few hands raised up. Padmini, we will take 2-3 questions at a time, and then maybe you can respond. Padmini?
Yeah, hi, am I audible?
Yes.
Yes, hi, sir. I had a query. Sir, what role do you think community-based committees, citizen-led committees can play in enabling the right to healthcare? Especially in areas like Jharkhand, Bihar, Bimaru states, because if you look at the situation in Kerala, you have the mothers committee, which comprises of mothers of children enrolled in Anganwadis. You have the village health sanitation nutrition committees. You have the Anganwadi level monitoring support committees, which are doing a very good job in taking healthcare to the grassroots, to the last mile delivery of public health, so to speak. So what role do you think these committees can play, if any, in places like Jharkhand, Bihar, and whether it would be possible to mobilize them on those lines once the act comes into existence?
Okay.
Thank you. Naveen Narayan.
Yeah. Thank you, Professor John. I think you mentioned the Bhore Committee before independence, 1946. And after dependence, we made Mudaliar Committee, 1962, Jangalwala Committee, 1967, Kartar Singh Committee, 1970. I think Jain Committee, Krishna Committee, Mehta Committee. So my whole objective, it is constituted for the different task and objective. My question, the brief of different committees shows the idea of health which was articulated by both the committee is being diluted by the government over the period. So is it possible now, and how we can take, because I'm also engaged in the Rajasthan, so how we can take forward from the government side and the private sector? What will be the action we can take? Thank you. Yeah.
So action we can take for
implementing the Rajasthan Act. So because the private sector and non-government sector as well as the government, because the whole history of government is absolutely not in favor of the people. So now the people, that's Naregas and RTI. So how we can take forward? Without taking forward, thing will not change as far as my understanding. I might be wrong on that ground. Yeah.
Okay. So, so about the first question from Padmini, there is no doubt that a well-functioning community committee can do all kinds of things for health, for healthcare, and for the right to healthcare and the right to health. I mean, you can do so much. You can do preventive work. You can help people to understand how to look after their health. You can help them to know about their entitlements. You can help them to organize for demanding quality services. There are all kinds of things that a good committee can do. The difficulty is to ensure that the committee is active and effective. And I think that is where Kerala is way ahead of many other states. And I think the basic difficulty in many states, including Jharkhand, is that when we talk of community and committee, sometimes there isn't much of a community. I mean, if you go to, in the case of Jharkhand, if you go to some of the Adivasi villages, there is a community. There's a community with a strong tradition of collective action and mutual support, and a lot of scope in these villages for active community committees. But then there are also caste divided villages with a very oppressive social structure, and in those social settings, it can be very difficult even to get people to sit together, let alone have an active committee. So I think that's one reason why a lot of these committees in places like Jharkhand have not been very active. And there are many. I mean, there are the school committees, there are the sanitation committees, and so on and so forth. And quite often they are not doing so much. So I think that is a larger challenge that goes well beyond the subject of health. That's really a social problem. That,
sir, just wanted to follow this up with another small query. Do you think self-help group women, especially in Jharkhand, there are quite active self-help group women, owing to the work done by Jharkhand Livelihood Promotion Society and Pradhan, as well as that stays the same for Jivika in Bihar? Like, these self-help groups, can they be a point of mobilization? Like, through these self-help groups, you activate committees, and that too that exist at the ward level or at the village level, like VHSNCs, Village Health Sanitation Nutrition Committees. Because I agree that villages are caste divided, but then these VHSNCs, which are at the revenue village or the ward level and not at the GP level, will also come to represent that particular caste, right? So it shouldn't be that difficult if we get the SHG women to mobilize them and do it through them. What do you feel?
Well, I think you're probably right, but I don't have much experience of how these SHGs work. But it's true that there are many of them, and they're quite active. Certainly in Jharkhand, I'm not so sure about Bihar. Right now, they tend to do other kinds of activities, but I think you're absolutely right that they could also be mobilized for something like healthcare and the right to healthcare, and they would probably welcome it. So I entirely support the idea of mobilizing them for this purpose. The second, Naveen's question, how do we ensure? I think you were saying, how do we ensure implementation? Yeah, I think that was the question. So I think that one of the most important things is to try to somehow make healthcare more of a political issue. I think that's where there is a real failure in India and in Indian democracy. How come it's a democracy, or we call it a democracy, and yet something that is as important as health and healthcare for the quality of life gets so little attention. I mean, that's a very striking symbol of the fact that this democracy, or so-called democracy, is actually a democracy for a small minority. It's a democracy for a small minority of privileged people who are able to use the democratic institutions, and the rest are just watching and just voting once every 5 years. And that's why, in so many ways, we find that the concerns and interests and rights and demands of poor people receive so little attention in public policy in India. But this is one more striking example. But these things can change. It's a matter of public mobilization. I mean, if there's one thing that is still possible in India, in spite of everything, I think it is to make noise. And in some states, again, like Kerala and Tamil Nadu, healthcare are lively political issues. They have been for a long time. And then there is now a party, AAP, that I don't necessarily, I'm not a fan of, but still they have, in their own limited way and limited fields, made education and health political issues. I think that's one interesting thing they have done. So I think that has to be done on a much bigger scale. And if that can happen, then I think the pressure to implement all these things, whether they are acts or schemes, will be enormously magnified. So again, the Healthcare Act can help. It can help to make healthcare a political issue, and it can help to put in place legal provisions that will put pressure on the government to implement what it is supposed to do.
Yeah. Sorry. एक सवाल है कि जो ज्यादा से ज्यादा प्रतिशत मेडिकल कॉस्ट का मेडिसिन में जाता है, दवाइयों में जाता है, और अभी हम देख सकते हैं कि फार्मा कॉर्पोरेट है काफी, तो इसमें क्या एफर्ट्स कर सकते हैं टू पुश फॉर एंटाइटलमेंट अंडर द राइट टू हेल्थ केयर एक्ट?
So I think I have not talked much about the regulation of the private sector, including drug manufacturing companies and so on. I think that's also very important. I mentioned that the right to health is a lot more than the right to healthcare. And I mentioned that to bring the right to health, we may need more than one act. And one of the acts that we would need is an effective act for the regulation of the private sector, including also drug manufacturers. That's a big agenda of its own. This goes beyond the subject of this talk. This talk was about the right to healthcare, but I think that if you talk about the right to health, you would also need something like, there is a Clinical Establishments Act. Some states have it. I think perhaps there's a national version also. But as I said, I learned in Tamil Nadu last week that this act is more or less not exactly defunct, but not being implemented. So that's another big agenda that certainly has to be looked at and discussed and so on. But that goes beyond the topic of this talk, because I don't have a lot of insight into this.
Okay, 3 more hands raised up. We can probably take these. Ganesh.
Hi, sir. My first question is about medical education cost in India.
Sorry, medical?
Education cost. If you want to be a MBBS doctor in India, the cost for to get education in private sector is huge. So how do you look at this issue? I mean, do you want to bring it in this whole umbrella of our healthcare system, or do any other take? Second, you talked about state list. The public health is under state list. You see the role of center. I mean, is there any way to demand center for the more resources for the public health, And sir, why does this public health or the public education doesn't become election issues during the election time? Thank you, sir.
So the last question I've already answered more or less, I think. I've said that the neglect of health is just one more symptom of the exclusion of the majority of people from democratic institutions. The privileged people in India, they don't need, or they think they don't need, public health services because they think they are being adequately served by the private sector. In fact, if you look at it, it's possible that even they need public health services because even the rich people are exploited by private health providers. I'm sure that all of you who are from middle-class families, you have some stories of relatives who have ended up spending huge amounts on private healthcare, not always with good effect. So it's possible that even the privileged, except maybe the super privileged, would benefit from a more rational and publicly based healthcare system. But the tragedy is that they don't see that. They think that they're well served by the private sector, and therefore they don't demand better public health services, and the rest of the population doesn't have much of a voice. I think that is the basic problem. But as I said, these things can change. I'm sure that if a bunch of people get together and decide that we are going to try to make healthcare a political issue, we are going to try to extend this effort to bring healthcare acts in other states. We are going to try to make healthcare an issue in the 2024 elections. I'm sure all these things can be done. About the state, healthcare being a state subject, I think in principle, I would be in favor of bringing it in the concurrent list, and I think it can be done, and some people have demanded that for some time. The only problem right now, I feel, is the nature of the central government, and as I said, the fact that it is so much hostage to business interests. So for that reason, maybe it's better if for the time being, it remains a state subject. But otherwise, in principle, I would be in favor of it being a concurrent subject. I don't have much to say on medical education. I don't think we can bring everything under a Right to Healthcare Act. If you put in too much, then it will become counterproductive. I think we have to make sure it covers an adequate range of issues and puts in place a foundation for demanding quite a lot of things, but we can't put everything in it. And I'm not sure that, I don't think medical education should necessarily come under that unless there's a specific link that we can identify with the right to healthcare.
Vijay.
Thank you. Hi, John. And John, मैं दो चीजें जानना चाह रहा हूँ. पहला कि आपने जिन कंट्रीज में आपने कहा कि यूनिवर्सल हेल्थ केयर सिस्टम ने लागू किया, बहुत सारे आपने कहा कि लगभग अराउंड 50% कंट्रीज हैं जिन्होंने हेल्थ केयर, ये अपने जीडीपी का कितना परसेंट इस हेल्थ केयर के ऊपर खर्च कर रहे हैं?
A lot more than India. I mean, India, look, listen, India is spending barely 1% of GDP on public expenditure. We're talking of public expenditure on healthcare. 1% of GDP, in a little more now than in India, okay? In other countries, it's 3, 4, 5, 6, 7, 8%. In all the rich countries, it's more like 6, 7, 8%. Interestingly, if you look at the US is now spending somewhere between 16 and 20% of GDP on healthcare, of which about half is public expenditure. So the point is that the healthcare system in the US is so irrational and so inefficient that it ends up spending more than any other country, even as a proportion of GDP. So in absolute terms, it's enormously more than any other country, with very poor results. I mean, the infant mortality rate is not very different in Cuba and in the United States, despite Cuba being so much poorer than the United States. So ironically, because the United States has such a badly designed healthcare system, even public expenditure on healthcare there ends up being similar to countries, let's say in Western Europe, like 7 or 8% of GDP. So they are not helping. So by privatizing the healthcare system, they are not helping themselves to reduce public expenditure. So basically, to come back to your question, the levels of expenditure on public healthcare in other countries are enormously higher than in India, and especially so in the richer countries of the world. So really, we really have a lot to catch up with there.
ये जी राजस्थान इसको लागू करना चाहता है, तो इट मींस कि अभी राजस्थान का बजट लगभग 3,500-4,000 करोड़ का है, तो इसको 12,000 to 15,000 करोड़ से ऊपर का लेके एक्स्ट्रा बर्डन और आएगा राजस्थान के ऊपर। राजस्थान ये मांग कर रहा है, और राजस्थान सरकार ने स्टेट असेंबली में इसको कहा भी है कि हम स्टेट यूनिवर्सल हेल्थ केयर को लेकर के बात की है। तो इसका मतलब राजस्थान को कितना एक्स्ट्रा बजट बर्डन इसके ऊपर लेके आना पड़ेगा राजस्थान के ऊपर।
Absolutely.
1%, अभी 1%।
Sorry, हाँ, प्रताप जी,
can I just make a comment on
yeah.
No, because this reminds me of an important point. Another real problem with the current version of the Right to Healthcare Act in Rajasthan is that it has removed an important provision in the previous draft, which said that the state government would spend at least 8% of its budget on healthcare. That was a useful provision. That would have made quite a difference. It would have forced the state to spend more. But that provision has been removed, and that also makes the current version of the act quite toothless. I'll have to leave in about 10 minutes. Is that okay?
Yeah. Hello? Yeah.
Hello. Yes. Dreze, I'd like to ask you one question, sir. So my question is, how would you respond to people who argue that healthcare is not a human right? Now, I've heard many arguments, and the main arguments are essentially that first, healthcare is difficult to define, and secondly, that all rights possessed by an individual imply a duty on part of others. And healthcare as such, you can't really define on who is duty bound to impose it. So how would you argue against this?
Well, I don't really agree with these arguments. I think you can make a case that it's quite difficult to define health as a human rights. I mean, it's not very clear exactly what it means and the implications are, because anyone can fall ill and we all have to die one day. So you can't really say if you're ill of an illness that is, let's say, you have a genetic illness. Now you can't go to court and say my right to health has been violated, or if you die, you can, all the more so you can go to court and say my right to health has been violated. So I think that defining and spelling out the right to health, that is quite difficult. But the right to healthcare, that is not so difficult. I mean, that is the purpose of the Right to Healthcare Act, is to define what the state owes to people. And therefore it satisfies this criteria. When you said that every right should have a corresponding duty, well, one purpose of the act is to define that duty. It spells out what the state commits to all the citizens or all the residents. So I don't really see why we should deny healthcare as a human right. I mean, I think it's possible to define it, and it is possible to define obligations that correspond to that right.
Thank you, sir. If I may ask one follow-up question, it's regarding that the most persistent problem in healthcare in India is the severe shortage of trained manpower in the medical field. How would you suggest a solution to this?
Well, it would help to spend more, for example. I mean, if we had more resources, we could have more medical colleges. I mean, there's no shortage of people who would want to become doctors if there were more seats. So I think that's largely a question of investment. And I think there's also a big problem in India, of course, of inequitable distribution of these resources. I mean, when you look across states, for example, at the doctor population ratio or the nurse population ratio, it's just amazing how large the variations are. And then within states, you have variations between urban areas and rural areas and so on and so forth, between the better off areas and the more deprived areas. If you look at China, it's far more equitable. I mean, they have, first of all, better human resources, and secondly, a far better distribution of human resources. So I think that's also something that has to change. But these are more matters of health policy. Again, I'm not sure that the healthcare, I mean, I guess the Healthcare Act can help to some extent because it will force the state to meet certain minimum standards everywhere and not just in particular areas or particular states. So it can help in an indirect way. But I don't think it's the main purpose of the Right to Healthcare Act.
Probably one last question. Raghavendra Yadav. Yeah.
Hi, Raghavendra.
आप अपना सवाल पूछ सकते हैं. हेलो.
Gone to sleep.
Okay, I guess पता नहीं, शायद ऑडियो नहीं काम कर रहा है उनका. So any final comments, Shankar ji?
We can have comments as well as questions.
Yeah.
But only in the next 5 minutes.
आप मुझे सुन पा रहे हैं?
हाँ हाँ.
Yeah, thank you, sir.
जी, आपकी आवाज आ रही है, पूछ सकते हैं.
जी, जो हमारा कॉन्स्टिट्यूशन ऑफ इंडिया है, उसमें जो आर्टिकल 21 है, वो हमको जीने का अधिकार देता है, और उसके अंदर जो है स्वास्थ्य का अधिकार भी आता है, जो मतलब कि फंडामेंटल राइट में आता है आर्टिकल 21.
Correct.
और उसके अलावा जो मतलब कि मानवाधिकार का एक सार्वभौम रिपोर्ट है, उसमें ये चीज कहा गया है कि जो राज्य है उसका दायित्व होगा कि अपने प्रत्येक नागरिकों को उच्च स्तर की जो है स्वास्थ्य सुविधा प्रदान करेगा. पहले की तुलना में अभी, जैसा चौधरी सर भी बता रहे थे एनएसएसओ का जिक्र करके, कि सुविधाएं बढ़ी है, लेकिन ये जो विस्तार हुआ है ज्यादातर शहरों में हुआ है. गाँव में अभी भी जो चिकित्सा व्यवस्था है वो झोला छाप डॉक्टर, मतलब कि जो अनस्किल्ड डॉक्टर है या अनडिग्रीड के डॉक्टर हैं, वो लोग के ऊपर डिपेंड है जो गांव का चिकित्सा व्यवस्था है, अकुशल डॉक्टर से. शहरी आबादी की कुल जो संख्या है वो 30 से 35% है, जबकि योग्य डॉक्टर और अस्पताल जो है वो 80% शहरों में है, और जो गांव की जनसंख्या है वो 60 से 65% है, और योग्य डॉक्टर और अस्पतालों की जो मतलब की हिस्सेदारी है वो 20% है. तो इसके लिए क्या करना चाहिए गवर्नमेंट को या पब्लिक को या लोगों को, सिविल सोसाइटी को, कि ये जो मतलब गैप है वो जो है इक्वल हो पाए? या जो अभी गांव अच्छी स्वास्थ्य सुविधाओं से वंचित है वो जो है वहाँ पे ये सुविधाएं पहुंच सके.
आप बिल्कुल सही कर रहे हैं. और आपने जो मैं पहले बोल रहा था कि ह्यूमन रिसोर्सेज आर बैडली डिस्ट्रीब्यूटेड, आपने इसके आंकड़े दिए हैं मुझे. थैंक यू फॉर दैट. सो यू आर राइट दैट द डिस्ट्रीब्यूशन, the maldistribution takes the form in particular of a poor distribution between rural and urban areas. But the point is we can do things to address that. I mean, if you look again at Tamil Nadu, in Tamil Nadu the distribution is better, and the reason is that they have taken steps to try to ensure that doctors can operate in rural areas. I mean, first of all, they have big reservation in medical education for SC, STs and OBCs. So a lot of the doctor staff comes from these communities, and there's less social distance between them and their patients than you would typically find in many other states between the upper caste doctors and the patients from marginalized communities. So that is one thing that helps to place the doctors in rural areas. And then of course they provide facilities, they provide quite often salary bonuses or special opportunities for further studies. So they basically have created a whole system of support and incentives to make sure that an adequate number of doctors work in rural areas. So I think we can take inspiration from that and try to do similar things in other states. I'll have to go soon.
Thank you so much, Jean. Sabah, will you propose the word of thanks? Thank you.
हाय जिंदाबाद जो मेरा नाम सबा है और मैं भी लोकतंत्र शाला के साथ काम करती हूँ. फर्स्ट ऑफ ऑल आई जस्ट वांटेड टू थैंक यू सो मच फॉर जॉइनिंग अस, और हमारे दर्शकों को भी बहुत बहुत शुक्रिया कि आप जुड़े, लगभग 80 पूरा टाइम जुड़े, और यूट्यूब पे भी काफी लोग जुड़े हैं. जॉ ने इस मौके पर हमारे साथ स्वास्थ्य सेवा का अधिकार पर रोशनी डाला, और आप सबकी चर्चा से लग रहा है कि अगर हम एक कदम पीछे हटे, ये पूरा हम सरकारी ढांचों में उलझे हुए हैं, पर अगर हम बस देखें तो एक तरह से जीने के अधिकार से बिल्कुल कनेक्टेड है ये स्वास्थ्य सेवा का अधिकार. तो और सारे तबकों के लिए, केवल अमीर लोगों के लिए नहीं स्वास्थ्य होना चाहिए. जो आई वांट आल्सो मेंशन दैट नॉट ओनली टू मेक healthcare more accessible, but also more efficient, egalitarian, and affordable. This law is necessary. और ये भी कहना चाहती हूँ कि आपने इस फैक्ट को, इस तथ्य पर प्रकाश डाला कि अनफॉर्चुनेटली, हालांकि भारत एक सोशल वेलफेयर स्टेट है, लेकिन हम 75 साल से हमारे लोगों तक ये बुनियादी हक नहीं पहुंचा पाए. स्वास्थ्य सेवा का अधिकार, ये गारंटी अभी भी नहीं है, बल्कि क्यूबा और अन्य देशों में उनके पास एक एगैलिटेरियन यूनिवर्सल हेल्थ केयर सिस्टम है जो क्वालिटी हेल्थ केयर भी देती है. और ज्यादा हम देख रहे हैं कि हम लोगों की जिंदगी, लोगों के जीवन को बाजारीकरण से, निजीकरण से जोड़ा जा रहा है. पर जैसे आपने कहा, ये कानून केवल ख्वाब नहीं है, क्योंकि काफी देशों ने लागू भी की है. और इस कोरोना महामारी ने हमारी खामियां दिखाई है. कौन स्वास्थ्य तक पहुंच पा रहा है, कौन स्वास्थ्य तक नहीं पहुंच पा रहा है. तो if there is any time to make this demand, now is really a time to make this demand that people's lives are not dispensable. इसलिए हम सब जो संगठनों से जुड़े हैं या नहीं भी जुड़े हैं, व्यक्तिगत संघर्ष भी कर रहे हैं इस डिमांड के लिए, ये एक बुनियादी हिस्सा बनाना चाहिए कि यूनिवर्सल क्वालिटी हेल्थ केयर होना चाहिए, ये कानून पास होना ही चाहिए, ये हमारा सबका हक है. फिर से बहुत बहुत शुक्रिया जॉन, and thank you to everyone who joined and asked questions and engaged. Thank you everyone.
Thank you very much. मिलते हैं.
जरूर मिलते हैं.